Welcome everybody to Taquitos de Sesos for the month of May. Today we have Dr. Hannah Combs. She is a second year neuropsychology postdoctoral fellow here with us at Baylor in the Department of Neurology. Dr. Combs received her undergraduate degree from the University of Texas. She completed her master's and PhD in neuropsychology in that specialty track in the clinical psychology program at the University of Kentucky, and completed her predoctoral internship at the Michael E. DeBakey VA Center here in Houston. Her research interests include self-regulatory dysfunction in Parkinson's disease and post-surgical cognitive changes following deep brain stimulation. It's been a pleasure to have Hannah work with us over the past year and a half, and I'm very excited to welcome her. The time is all yours, Dr. Combs.
Thank you, Dr. Strud. Thank you for inviting me to give this talk. As you can tell, my research interests do not necessarily line up with what I'm presenting on. I'll give a little background for why mental health in rural communities is particularly touching and a special topic for me. So before we get started, just some of the main objectives, what I'm hoping you'll get out of this talk is first to identify some general health disparities within rural communities. Also understand unique characteristics of working in rural settings and with rural clients. And we'll wrap up the talk by discussing efforts to improve access to care and improving access to mental health and neuropsychological services in rural settings. I have no conflicts of interest to disclose. I do want to make a disclaimer. I am by no means an expert in rural mental health or rural neuropsychology. My interest in this topic has gone back since graduate school. University of Kentucky is located within Lexington, and that's central Kentucky, which serves most of the eastern region of the state as well as parts of West Virginia. So we see a lot of folks back in Lexington, a lot of folks from Appalachian regions. And it became quite imperative to understand and kind of familiarize myself, as with all my grad school colleagues, into Appalachian culture and as well as other just general rural culture. And from that, I found it been very helpful taking it as I come back to Texas, here in Houston, working with clients from more rural areas of the state. So just to start off with, and talking about the rural communities, kind of what am I discussing and kind of how much of the U.S. is considered rural? So over the past century, the urban landscape of the U.S. has changed, and with it, so have rural areas. In the census in 1920, approximately 54% of Americans lived in rural settings. And by the 2010 census, that number had gone all the way down to 19.3% of Americans, which comes out to be about 60 million folks currently live in rural areas. It's important to note that although the numbers are dropping, the amount of landmass that is considered rural is still quite high. About 97% of the nation's land area is technically considered rural. So for us in neuropsychologists, thank you to the 2015 most recent salary survey, giving some figures on where neuropsychologists are working, we have about 8% of neuropsychologists who work exclusively in rural areas, and then an additional 11% who function both in urban and rural settings. So at first glance, I was pretty pleased with this. So about 19%, roughly the same as the census makeup of who is in a rural setting. We are actually consistent with that figure. But if you take into account, again, that landmass, so 97% of the US is rural, I highly doubt that we are actually capturing these 19% of folks who are living out there. Typically, practitioners in rural settings are kind of in little clusters, and maybe the larger towns of rural communities, there's still a lot of areas that are untapped. So for those of you who are familiar with the Taquitos de Sesos presentation, it might seem interesting as to why we're talking about rural culture. But so I wanted just to talk briefly about why are we even discussing this in this setting. Really, cultural competency and a newer term, cultural humility, have been identified as essential considerations in addressing all health disparities. But unfortunately, while the cross-cultural literature is growing, there's still little guidance on how providers can grow within their cultural competence and cultural humility with working with rural individuals. So what is rural culture? Although there is vast heterogeneity within rural communities. There are some distinctive features that have emerged that are often linked with rural culture. Some of these features include importance of family. Some communities are often kin-based. There's also a strong sense of independence and autonomy, an importance of the connection to the land or place. Many folks who live, born and raised within rural communities have a very strong sense of where they live, the land that they live on, and how important it is to pass on to future generations. Conservatism is another main attribute. The importance and influence of faith and religion, and as well as using informal networks, getting information from friends, from other community members, things that we may not actually reach out to for medical help here in more urban settings are much more typical within a rural community. So other characteristics associated with rural residents are a strong work ethic, a tendency to value social norms and traditional roles. And just to comment, this focus on traditional roles and social norms, it can be difficult for those who don't fit in for them. The rural communities have been likened to a fishbowl environment. You're in a situation where details about individuals' lives are more easily known and discussed by others around them. And of course, like with everything, these cultural traits are generalities. They may or may not apply to all rural communities or all individuals living within a rural setting. It's important to avoid stereotyping rural culture and using general assumptions that may not apply to particular rural contexts. And as with other aspects of culture, such as race and ethnicity, the complexity and heterogeneity of rurality should be considered and respected. So to appreciate the need for rural cultural competency, rural cultural humility, it's useful to examine what we know about health and mental health within these communities. So in general, rural residents are more likely to report fair to poor health status than their urban counterparts. They're more likely to be obese, to not be insured, and as a result of this, report having deferred care, medical care because of the cost. There are also some main socioeconomic differences that impact between urban and rural settings. Rural communities are typically older, and this is true across the years. If you look at the census data, over time the percentage of older adults is increasing while the percentage of younger adults is decreasing. And this appears to be just the tendency for younger generations to flock to more urban and metro communities. There are higher rates of poverty, and there are less access to appropriate resources within educational settings. So just some little tidbits to support this. Obviously, there's the much more comprehensive literature on the effects of poverty, education, things with socioeconomic differences. But just to highlight a few of them, rural schools offer half as many advanced mathematics courses. On the figure to the right is a bar graph actually showing the high schools that offer at least one advanced placement course. And you can see that rural communities are less likely to offer any AP course than their urban counterparts. And although rural students are actually more likely to graduate high school, they're less likely to go on to college and ultimately graduate from college. So within our kind of group differences between urban and rural, just generalities, often they're lower educations as adults. And epidemiological studies indicate an increased risk for severe mental health problems among rural residents. Within substance use, there's increased incidence of alcohol abuse and dependence among rural adolescents, and rural adolescents are more likely than their urban adolescents to drive while under the influence of alcohol. Depression is nearly twice as common in rural women than urban women, and there have also been reported to be about 35% higher suicide rates than in urban settings. So this next kind of portion of the talk is going to be focusing on things that are important for neuropsychology. And really in this, I'm focusing on what are normative data and how it's used within these settings with these clients and maybe some limitations to that, but also some of what we know about cognitive differences between urban and rural residents. So unfortunately, as most of us know, the neuropsychological instruments that we use and that are widely available are not only sensitive to dysfunction. They're strongly related to age, education, other factors that we may not actually be trying to assess when we're administering these tests. Most of our normative data is based on high school educated, white, urban dwelling adults. And quote unquote normal subjects can be misclassified as impaired when using just standard cutoff scores, especially if the individual is older, less educated, and less intelligent than the normative group. One study actually was looking at whether or not who was more likely to be actually misclassified as having dementia when in fact they did not. It's more likely to occur in healthy elderly persons with low education. So low education is more likely to flag a false positive for this person actually has a dementia process. And another study showed that about 50% of rural older adults scored below the published cutoff scores for cognitive screeners. And the cognitive screeners they're referring to within this study, and this is Kittner et al., is within the MMSE and as well as the dementia rating scale. So some of the literature, I will just make a caveat. Really, there's not a lot of literature among the differences between urban and rural residents as it pertains to neuropsychology, as it pertains to cognition in general. The few studies that I was able to find not only come from the US, but are actually better represented across the globe. Other countries seem to have a higher priority on understanding urban and rural differences than we do here in the US. So we'll start with kind of what has the research shown as it pertains to differences between children and adolescents from rural communities as compared to urban communities. So in 2014, Tyne published an article investigating the differences in working memory of children living in poverty in rural and urban settings. Verbal and visuospatial working memory tasks were administered to 6th grade students living in a low-income rural, low-income urban, high-income rural, and high-income urban developmental contexts. Both low-income rural and low-income urban children showed working memory deficits compared with their high-income counterparts, but their deficits were distinct. So unlike, as you can see on the bar graph on the right, the urban low-income children actually showed symmetrical weaknesses within both verbal and visual spatial tasks. But their rural low-income students actually showed this asymmetrical pattern. They have more extreme visuospatial working memory deficits than verbal working memory deficits. And I'll return back to this idea of verbal visuospatial differences within urban and rural settings here in a bit. So, as I mentioned, other countries have looked at this a little more closely than we have. In Mexico, in 2013, Galindo and colleagues analyzed complex visual object processing in 6-year-olds from urban and rural primary schools. Rural children perform more poorly on visuospatial processing and visual memory tasks. On the right, you can see actually an example that they included within their article, the left reflecting a typical urban resident, and the right showing the art and the drawings by a rural student. And what kind of came from this is not necessarily saying we think that there are truly differences in those who live in rural settings or urban settings, but that there actually might be some more information that we need to understand about how are these skills being developed and how we're testing them. So for the Galindo and others have actually speculated as to rural and urban children develop visuospatial skills differently. And if you think about this, this does make sense. So within a city, a child will learn how to find their way around based on streets, based on crosswalks, based on signs, things that are fitting for their environment. And a lot of our tests might actually rely on some of those skills that are developed specifically within urban settings as they're developed by folks who work in urban communities. This is in contrast to rural children who may understand their sense of space by landmarks. So instead of understanding where you are in relation to a street corner, they may understand where they are and grow that ability based on where they are from the river or the mountains and different actual landscape landmarks. In Thailand in 2013, they investigated their understanding of urban-rural differences within educational achievement. So why is it that it seems as though individuals and children end up having lower education in general, but lower educational achievement skills as well within Thailand? And part of it was actually just trying to see what were the factors that were influencing whether or not someone graduated high school, were doing well in school. And for the urban students, socioeconomic status came out to be the most important factor. The SES of the family is what predicted their educational achievement. But for the rural students, it actually came down to the educational resources. So the opportunities they had in the school, the resources the school actually had, as well as their mother's education level, as the most important variables for how high a student achieved in terms of education. And the author speculated as to the reason why mother's education was more important than, say, father's education or SES, was the idea that within Thailand, a mother's education is important, as in lower education means they most likely are having to work jobs that have longer hours, means they're not at home as often, aren't able to teach and educate their children on a day-to-day basis the same way a mother would who had a higher education and had a job that was not as time constrictive. So moving on to adults and older adults, and what are some of the differences that have been seen between these two groups. In China, in 2014, they actually show that there appeared to be a higher prevalence of dementia within rural settings. But as we have mentioned education a few times now, the relationship between dementia prevalence appeared to be moderated by education. And in 2010, just a comprehensive neuropsych evaluation comparing adults and older adults from rural settings to urban settings within China show no difference in global domains of neurocognitive functioning, but if you actually looked at individual measures, the urban participants appeared to be actually have stronger performances in select measures of processing speed, executive functioning, verbal fluency, and verbal learning. And then yet again, as we come back to education, if you actually controlled for the academic skill use, so their ability, their reading level, their writing level, if you actually control for this within the analyses, most of the urban-rural differences disappeared. And what emerged were actually some rural advantages in select measures of visual reasoning and motor dexterity. In Mexico in 2018, Science and colleagues described differences in cognitive functioning across rural and urban areas among older Mexican adults. And respondents residing in more rural areas often perform worse across all cognitive domains. This was explained again by lower education in rural settings. And they speculate as to the poor cognitive functioning in late life may actually be the result of the historical educational disadvantage in rural areas or selection through migration from rural to urban regions for employment. And then lastly, in Portugal in 2010, Nunes and colleagues estimated the prevalence and attempted to describe the pattern of cognitive impairment in rural and urban populations from northern Portugal. And within their study, they also found a higher prevalence of cognitive impairment in rural populations as compared to urban populations. So the main takeaway, I think, from this literature is that it's pretty limited. We don't have a lot of studies. They are across the globe, which is great that we're studying this in other countries, but it means we don't really have this understood. The best explanation that is consistent amongst the studies we do have access to are that education is playing a strong role in this, and which makes sense. As we discussed, we know that our tests are highly influenced by education level, and we're still further understanding how different things within developmental can shape your performance on our neurocognitive tests. In 2001, Wackerbarth, I apologize, can't say this name correctly for some reason. Wackerbarth and colleagues actually investigated differences in the consumers of a memory disorders clinic. So they compared patient characteristics and family perception of patient function at an urban memory disorders clinic and a rural memory disorders clinic. This was a cross-sectional data analysis of first-time visits who first presented to their memory disorder clinics, and a little under 1,000 folks were examined in total. This was a condensed battery. This was more just kind of functioning, characterizing the patients within the clinic. So they gave an MMSE, an activities of daily living, both basic and instrumental checklist, the Blessed's dementia rating scale, and revised memory and behavior problems checklist. So the results of this study, first off, actually, patients and family members in both clinics, both urban and rural settings, were more likely to be female. The urban clinic patient was significantly more likely to be living in a facility than the rural resident, and more likely to be educated than the typical rural patient. Urban and rural patients did not show significant differences in age and education adjusted MMSE scores or raw ADL and instrumental ADL ratings. So despite reporting similar levels of functioning and similar MMSE scores, urban family members reported more memory problems, twice as many personality changes, more frequent behavior problems, and more adverse reactions to problems than the rural family members. And we'll return to this idea in a bit. The idea that potentially the differences within family reports of patients actually might come down to some of those traditional values and some of the maybe stigma and beliefs about mental health within rural communities. So moving on to some of the unique characteristics within rural settings. We've discussed kind of just general numbers about who's living there, some considerations when working within a neuropsychological practice, but what are the unique characteristics of actually functioning as a mental health provider, not just a neuropsychologist, within a rural community? So although there's greater diversity among rural areas, there are a number of common characteristics that differentiate rural from urban settings. The first one, limited resources, travel distances and costs, professional isolation, and beliefs about mental health practices. And we'll go in depth into each one. So the first one, limited resources. A characteristic inherent in rural communities is the limited availability of resources, especially psychology and neuropsychological services. And although a smaller proportion of rural dwellers in the U.S. as compared to other countries, inequality in the distribution of psychologists to rural areas have been reported, with approximately 1 psychologist per 7,000 to 10,000 residents in rural areas. And over half of U.S. counties have no practicing psychologist, psychiatrist, or social worker. Due to limited specialist healthcare providers, those practicing in rural areas may be prone to a generalist view of care. The implication is that rural psychologists and neuropsychologists are more likely to be approached to assist individuals with a vast range of problems, which may be highly complex in nature and not within their broad area of expertise. These individuals may also lack the network of other specialists to whom they can refer such clients, as they may be the only professional available to provide treatment. In 2006, Campbell, Kearns, and Patchen sent out a survey to all of the psychologists, not specifically all, to most of the psychologists within Oregon to assess the perception of needs and resources by both rural and urban psychologists. So a total of 187 psychologists responded to the survey. Just to mention they had about 50% response rate. All rural psychologists, all 202 rural psychologists were contacted. Given the disparity between the number of rural and urban psychologists, there was a much longer list of urban psychologists, so every 7th urban psychologist was contacted in order to get roughly comparable groups. So, although obviously caution should be used in generalizing the survey findings of Oregon psychologists to all U.S. psychologists or psychologists outside of the U.S., there are likely many similarities between the practice settings of psychologists in Oregon and psychologists in other states. Also, there's more of a clear division of rural areas in urban practice settings within Oregon, so this survey may actually provide a useful example of rural and urban practices. So what did they find? In general, rural psychologists rated having less access than their urban psychologists counterparts to psychotherapy services, appropriately trained medication prescribers, psychological testing services, comprehensive psychological assessment services, services for children, couples and families or adults, community education programs, and substance abuse treatment. So in general, rural psychologists reporting pretty much across the board of all of the main areas of resources that a psychologist may need in terms of referring out or making sure that they have appropriate care and are competent to work. They're reporting feeling more limited in having greater needs than the urban psychologists. So the next characteristic is related to travel distances and costs. Longer travel distances for clients and clinicians means more time and money. Obviously, for these portions, I'm referring mostly to for the clinician who's in the rural setting, but this obviously impacts our clients in every urban community. Because of the lack of resources within the rural settings, you're going to see and likely often see folks from rural communities. They are spending more time and more money to make it to the appointments in a situation where they have limited public transportation available. So there are relatively few taxis or any transportation services for individuals with disabilities in rural settings, implying that they have to be booked well in advance and waiting times are often prolonged. Also, within this travel distance, it can be unpractical for some clients to attend a face-to-face evaluation, let alone return for a feedback session, which will limit the services that may be available to them. Providers also deal with the challenge of accessing and maintaining a network of professionals to whom they may refer clients and consult with regarding supervision. Access to professional resources such as libraries, conferences, professional workshops is difficult due to the isolation of rural communities from such resources. Although, of course, internet and telemedicine has significantly improved rural neuropsychologists' access to up-to-date information, research findings, supervision, and support, the in-person professional development workshops are imperative to help reduce the isolation, reduce the possibility of actual burden and stress relief of the practice when you actually have people to meet with face-to-face. So although these are great resources and a lot is being done to try to increase development, professional development opportunities in rural communities, it can still pose a challenge for those living more isolated. So the final characteristic of particular relevance to rural communities is that of values and beliefs regarding psychological practice. And neuropsychologists working in rural practice need to be aware of these potential beliefs and characteristics. So residents of rural communities may be skeptical about seeing a psychologist or neuropsychologist and may view the option of seeking such a service as a last resort. You might end up seeing individuals much further into, for example, for Alzheimer's, much further into the dementia process than you might for someone living in an urban setting, based on some of these stigmas around mental health. Such attitudes may result from a lack of exposure to the psychological profession or a heightened degree of stigma attached to psychological difficulties in rural communities. Research has suggested that the trait of stoicism may mediate a rural dweller's tendency to seek help, and rural communities may lack knowledge concerning the different services offered by psychologists, particularly psychological services that may encompass non-mental health issues like clinical neuropsychology. So what can be done? We've been focusing primarily on just identifying differences, noting characteristics, and kind of things to keep in mind when working with these clients or if you work in one of these communities. But there are efforts to improve access. So one of the ways in which we could improve access is to increase recruitment of mental health providers to rural and underserved regions. The website that I have listed up here is for 3RNet, and this is a national nonprofit network of members committed to matching healthcare professionals with rural and underserved jobs. And another attempt and idea has been to integrate psychological and primary care practices, either by having both psychology and primary care housed together, or something else that has been pushed, and as Sammons argues, that training in psychopharmacology for psychologists may lead to better medication management, and it may actually help streamline and help meet the greatest perceived need within the community for psychologists, because instead of having to find more and more individuals who can provide medication management when you're already in an isolated individual within these in isolated region, having the opportunity to prescribe, having medication management skills can help kind of bridge that gap. And of course, telehealth, telepsychology, teleneuropsychology, I could give a whole presentation on it. I am not an expert on that. I know we have some folks on here who actually are. And we're not going to focus in on that because that's its own topic in itself. And this is a great way, and great strides have been made within access to care based on telehealth means. It's by no means a cure-all for the issue of improving access. We still have the concern of limited internet access, or even if they have internet access, spotty service. And so the quality of telehealth and how feasible it is in the most remote communities is still not very strong. Hence why we have to kind of consider other opportunities to improve access. And then the last bullet point for here, recent efforts, have been the idea of tax sharing and tax shifting. This is a concept that was actually quite new to me until I started working on this presentation. And it was interesting, almost one of those concepts that seems obvious, but it's actually fairly well thought out, interesting, is something that the World Health Organization has been pushing. So tax shifting has been proposed as a way to address unmet mental health needs. And given the shortage of mental health specialists in rural areas, tax shifting has been suggested as a way in which to address unmet mental health needs in rural and other low resources area. So tax shifting is shifting tasks from more to less highly trained individuals so that you can use resources more efficiently and to allow all providers to work at the top of their scope of practice. So on the right is a World Health Organization pyramid conceptualization of how this would play out and kind of the different levels and shifting of tasks that would occur in order for individuals to actually receive access to care that they may otherwise not receive based on where they live. So initially, tax shifting was the term being used. Lately, it's actually changed to task sharing. And the task sharing has been used more recently to describe this concept, as it more accurately describes that care must be shared within a team of providers. So this is not simply referring out to another person. This is actually collaborating with other providers, either between two rural providers or between rural and urban providers. This may look like a team may include a psychiatric consultant and care manager who engages the patients while following up on depression symptoms, such as in a collaborative care model, and or include a community health worker to increase access to care. So the idea is that if we can't recruit specialists within the most remote areas and the most secluded spots, maybe we can have someone who's actually functioning more as a trainer, a supervisor, or a consultant rather than a direct service provider. So just last year, a systematic review was published in the Journal of Rural Health, investigating kind of the feasibility of task sharing for rural mental health care delivery. And what Hoft and colleagues determined was that task sharing is already occurring through the work of community health workers, non-mental health providers in primary care, and mental health specialists. And that's kind of, I guess, reflects my initial take on this, was this seems pretty obvious because we're already moving towards this model. The idea was that this is something that, though, can be used more often and actually used as a systematic change for how do we address the needs for these individuals. So telehealth, as one aspect of task sharing, can assist sharing of tasks both throughout supporting care delivery with the help of a remote team member and through provider education. Task sharing may involve challenges, though, related to professional boundaries, confidentiality, burnout, and staff turnover. So for those of you who are in the United States, a great resource that I found in terms of learning more about rural health practices, finding services within local areas, I stumbled upon the Rural Health Information Hub. I wanted to make sure, and I at least included this in here so that I can maybe promote its use and share all the great resources that it has. So the RHI Hub, it's funded by the Federal Office of Rural Health Policy. And within this database, it's actually a national clearinghouse on rural health issues. They have a section within their website of rural health models and innovations. And the rural health models and innovations includes programs and interventions that were conducted in a rural location in the United States, address a rural health topic or issue, are of interest and potential use to other rural communities seeking program ideas, include a program contact person, organization, or other credible source for finding out more about the program. So the idea is that they came up with basically a database of programs that are already going on in rural locations and to keep track of how effective they are and whether or not they can be adopted elsewhere. So each program included in the Rural Health Models and Innovations is identified by the level of evidence available for the approach. So I won't go into all the detail about what's on the table, but just to give an idea of kind of how they're classifying the programs that they include within their database. So the highest level within their database is evidence-based, and in order to be deemed as having an evidence base, there must be a review study of the approach in a peer-reviewed publication. It needs to have been tried in more than one location or setting, and obviously the results needed to be positive, and that it can be useful in all formal contexts. So the idea is that the evidence-based programs are ones that that others could adopt if interested, and that it should be an effective effective program within their locale. So effective, kind of one step down from evidence-based, is that it has been published in a peer-reviewed article. There hasn't been a review paper on the topic, but it may only include a single location, setting. It can be both, but it's more limited in scope of where it has been tried. Results still need to be positive. And the idea is that they are wanting to make sure they're including things that are being reported, but that research is still needed to determine whether or not they are as effective as they hope it to be. And so potential uses for effective programs are that they can be cited in formal project proposals and grant applications when there's a lack of relevant evidence-based research and programs. And that actually reminds me, the RHI Hub, there are actually grant opportunities for these programs. They're up-and-coming programs to receive funding through them. Promising evidence means it's much more limited. They may not actually have published any of their work yet, but they're doing program evals that seem promising. There's some positive results. And emerging are any project not labeled as evidence-based, effective, or promising. So it could just be an anecdotal account of a program without documentation of a formal evaluation. So it's important to know kind of the level of evidence of the programs that are available within this database, but it's also in the spirit of kind of making sure all potential opportunities are pursued. I appreciate that they include emerging programs because some of the next big, the next top ways in which we can actually expand resources may be through some of these emerging programs that just need more visibility. So just a subset of the mental health programs that are currently featured and proposed within the US. So unfortunately, there's only one mental health model and innovation listed, and that's mental health first aid. So this is an 8-hour course that trains rural community members to recognize mental health and substance abuse issues and learn how to help someone who is developing a mental health concern or experiencing a crisis. This is actually an aspect of task sharing, so educating individuals in rural communities where they may not be the specialist present, but training them on how to identify when extra services are needed, kind of the lower level skills that maybe the specialist doesn't need to be on site, but other people can help be there to kind of triage care. There are a few effective examples, and the first one mentioned on here is actually work that's being done through Texas A&M. The Madison Outreach and Services through Telehealth Network, the MOST network. This is a network formed to bring counseling services through telehealth systems and community health workers to Brazos Valley, Texas. Both the other ones that are on here, also other telehealth, telepsychiatry services and programs that have been shown to be effective, and there have been peer-reviewed publications related to the program, both here at the Portland VA and within the University of Vermont Medical Center. And then the last one I just wanted to include here, a couple of promising examples. And these are ones that research is still needed, but the preliminary results of the formal kind of program evaluations have been positive. So one of which, the Healthy Outcomes Integration Team. This is designed to treat adults who have a serious mental health condition and those who have or are at risk for developing chronic health conditions. Crosswalk, which is a program that integrates behavioral health care into primary care services. This is in Michigan's Marquette County. And Physical and Behavioral Health Integrated Care Project. It's supposed to be a one-stop shop of healthcare services addressing the physical and behavioral health and medication needs of adults in the region. So you can see most of these programs are involving telehealth and task sharing in order to meet the needs in these areas that maybe recruiting more specialists may just not be feasible for the time. So that is all I have for today. Hopefully you have learned a little bit more about rural mental health and neuropsych considerations when working with rural clients. This topic can go much deeper, so I've only scratched the surface. If you have any questions about the topic or about just anything in general that I shared, please email me. My email is hlcombs@bcm.edu. And thank you everyone for joining us.